there, and welcome to the Hit Like a Girl podcast. My name is Joy Rios, and on our show we amplify and celebrate the contributions of women in the healthcare and health IT space. We talk about how complex healthcare is. It's a lot like a 30,000 piece puzzle, and each one of us holds a piece of that. And so our intention here is to learn from one another. So today on my show we have Holly Varnell, and I would love it if you'd take a moment to introduce yourself and just let us know a little bit about you.
It's kind of hard because you know me
That's
already.
right.
But
That's a good point. Let's talk about that. So Holly and I know each other. We've actually worked together for several years, and we have past lives together. So what part of our conversation gets to be about value-based care, because I know this about you, that she is somebody who can get into the weeds and very, very nerd out about clinical quality measures and merit-based incentive payment system. And that used to be something, to be honest, we've traveled together. We know each other somewhat intimately, have worked with a lot of clients in the past, and it's been really interesting to watch your journey just over the years. And so you and I haven't kept in super close touch. So since we used to work together several years ago, what have you been up to?
Honestly, I feel like I've bounced all over the place.
Not really.
A couple of places. So after doing the consulting with you, I got really interested in molecular testing and biomarkers. And I started working for a genetics company and started working with hereditary genetics, and then got into molecular proteomics space now in prenatal, and really trying to make a difference with different companies and different underserved populations. One of the things that I've done in the past, which I'm not sure you're aware of, is a VA initiative. And I worked pretty hard on it for patients with prostate cancer, for veterans with prostate cancer.
Right.
Who were exposed to Agent Orange during Vietnam, Gulf Wars. They are at higher risk for being more aggressive, and it travels more quickly, and you want to be able to catch it before it's too late. So I was fighting to get covered a genomic test that would stratify that risk. And now I switched over to this brand new company that created a space in prenatal care that didn't exist before. And it has really changed my perspective on things, because I didn't realize what disparities there were in maternal care. Mm-hmm. And I didn't realize that there wasn't any clinical quality language or the ability to measure anything in prenatal care. So that's something I'm focusing on now.
So one thing I know about you is that you like to tackle large, complex problems, and you just really get into, so understanding you had a passion for genomics testing. Can you tell me about that? You probably have so much information stored up in your head that it might be difficult to get it out, but can you give me the basics of what you know? What would a layperson need to know about genomics testing and the support you were doing in the VA, if we can take that for just in 2 minutes.
Try not to nerd out with it too, but I did a lot of research, obviously, because I want to be able to do things that I know is actually going to make a difference. So, for example, in the VA, the genomic test was actually based on how the cell within a tumor, or how it grows, how the tumor grows. So as the cell proliferates or multiplies, it grows. And we would have a molecular test that could tell you how quickly that was happening. Okay. So it could tell you the aggressiveness by telling you how quickly the cells were regenerating itself.
And so the idea being, okay, we're going to try to get ahead of that, right, and test people as soon as possible to prevent the cancer from, spreading and being in its worst
Yeah,
possible
and especially
state.
in the VA, because in the VA there tends to be a lot less attention and a little bit of lack of care and lack of access in some cases. So knowing that you can really set aside a population that you really need to focus on, and pay more attention to them.
And so now you're in the maternal state, in the maternal area, and the thing is, there's a ton of terrible statistics about maternal mortality, infant mortality, and when we look at how the U.S. is performing, for women as far as their health outcomes when it comes to maternal care, we have a lot of work to do.
Oh yeah.
Yeah, and there's a number of reasons for that, whether pregnant women have not been able to be part of clinical trials just by law, and there's been a lot of prevention and really just lack of focus on some of measuring what matters. And I think that what you're trying to touch on is, if I'm familiar with what you're getting into, and this is an area that we share in common, is an understanding of clinical quality measures in particular. So kind of giving an overview for lay people, as people that are not as familiar, and we have gotten into the trenches of this with value-based care, is that there is a menu of clinical quality measures that administrators, clinicians, doctors around the country can focus on, and they're essentially going to report that to the government. And those are created with evidence. They have to have clinical relevance, like why are we measuring this, and a lot of technical input that goes into in the generation and creation of clinical quality measures. I don't want to put words in your mouth. However, I might try. Is that from what I understand of what you're doing is we have not measured any meaningful aspects around maternal care, and you are trying to create that. Is that
correct?
A fair statement?
And around infant care. So the newborn.
So can we talk about what goes into the creation, because it's a technical process. It's not something that, you just happens overnight. A lot goes into it. So what's your thought process behind creating a clinical quality measure around maternal care?
So one, I want to touch on the disparities part and the health equity part, because you mentioned that before, and that's really kind of gets into the weeds of why I'm doing it, so kind of help to understand the madness of it. So right now the focus is on preterm birth. We have more than 10% of all births are preterm births. And right now on guidelines, we only have the ability to screen about 17% of mothers. So there's 80% of mothers that are out there that aren't being screened, that are having preterm birth unexpectedly.
What would we be screening for?
So screening for any pregnancy complication, screening for different clinical factors that can lead to pregnancy complications, or if you're diagnosed with a complication, following up with care, change in clinical care management. But one of the things that I realized that was kind of shocking to me, because I'm pretty new to the prenatal space, I've consulted in, as you know, a lot of different specialties, but prenatal I wasn't as familiar with, and I learned that there are guidelines that don't have very specific things for very specific individuals. And for example, African American women, we know that they're 1.5 times more likely to have a preterm birth. For American Indian, Native Alaskan, they're 1.25 times, I believe, more likely to have a preterm birth. So these are the people that are in the population that we're not screening. So to start to identify some of these underserved populations and be able to truly provide something that would change medical management, I began to create first clinical quality measures that measured providers, hospitals, employers, payers across the board on whether or not they're doing a risk assessment early and for this specific population, and whether or not they're actually making a change in medical management if they do that.
So right now, from what I understand, the clinical quality measures that are relevant to moms have to do with postpartum care, and it's basically after, obviously, the baby has been born. So the idea being of hey, we need to put our eyes on something a lot sooner, correct?
Yes, and make it more feasible, more reproducible, more functional for it to actually work. So a lot of the measures, or there's 1 or 2 measures out there, and almost all of them are structural, or they don't really try to identify other factors. So with these clinical quality measures, I'm risk stratifying them out into different clinical factors, including social determinants of health, because you can code that in clinical quality language, socioeconomic status, by payer, by provider type. So I mean, it gets crazy to actually think about what we're getting. So not only are we holding people accountable for doing these measures with those outcomes, at the same time we're gathering so much information that can lead to other preventions for pretty much any pregnancy complication.
So
it's
I
really
love
cool.
I love nerding out with you because you're one of the only people that I can talk to about the types of measures and really like know
Yeah.
what we're talking about. And like, okay, so there's structural measures, there's process measures, there's outcome measures, and there's patient-reported outcome measures. Are the measures, and think about that, like structure would be like what pieces are in place, right, to capture some information. Process is a little bit more related to workflow. And when you think of outcomes, that's like the golden ticket, right? Like we
Yeah.
want to have better outcomes. So are the quality measures that you are looking to, create, would they be outcome or patient-reported outcome
So
measures?
it'd be a mix of both because you have to ease into things certain ways, but definitely the whole point is change in medical management to change what's happening. The measures we have right now are saying the same thing we already know. We know the diversity. We know what's going on. It's how do we fix it and what's a good way to do it. So definitely, it's for both the mom and the baby.
All right. And so then how do you gather all of that information? Because that's a mountain in and of itself.
So that's technical
Okay.
and difficult. So you find any pregnancy-related condition for high risk, and it could be non-pregnancy related too, but you find these value sets, and they can be procedure codes, they can be diagnoses, but they can also be things that are interoperable. So since there's never been any clinical quality language for maternal care, it's not interoperable. So systems can't, hospital systems, EHRs, they can't talk to each other. So that's the main thing, and to make it interoperable, you have to take these diagnoses, procedure codes, and link them to SNOMED codes, to RX norm codes, and then it gets really technical, and you got thousands and thousands of, not hundreds and hundreds, hopefully we'll get to thousands, of different points that you're doing with the value set, and then you're extracting all of that information, and then we have a registry that we're working with, actually Lauren Patrick, that you know,
Yep.
the CEO of HealthMonics, she's working with us, and she is able to pull in all that data, and we've mapped out, or they will map out where the outcomes are and get that, but we'll also have all of the other stuff.
Yeah, I mean, so that's a really sophisticated technology that she's got. It's been really powerful in helping people understand their data and to try to get the best performance out of it, which ends up working towards education, training, workflow changes. Like you just think you're looking at like a bunch of numbers, but they are very, very meaningful behind them. And so you have are you interested in telling us about your initiative that you are working on? I feel like it's a big deal.
Yeah. Well, it's become a big deal. A lot quicker than what I thought it was going to, definitely. But
you're like, I had an idea,
Yeah.
and then turns out.
I had an idea.
Yeah.
It turns out everybody wants, to support this, which is really phenomenal. So I call it Dream Big in Maternal Care. It's driving equity for all moms and babies by improving gaps in maternal care.
Okay.
And it really does focus on health equity as well as holding people's feet to the fire on these clinical quality measures and on really starting to make a change.
So can you share more about like what would be your vision if we're dreaming big? Like what would be the ultimate goal as far as, well, not even the ultimate, even a milestone, because even when you get to it, it's just going to be the beginning of the next mountain, I'm sure.
Right. Well, I mean, the ultimate is kind of mind-blowing, honestly, to me. But if you think about it, we can have all this data. We're going to know all of these preventions. We're going to know all of these pregnancy complication risks. And we're going to be able to provide medical management because we're measuring outcomes at the same time. So we're building evidence for what we need to change while we're finding what needs changed clinically and in other socioeconomic factors. So we have all of this information, and now we have it in this clinical quality language, so it starts to go back and forth between electronic health record systems. So imagine, let's say, if a clinical decision tool popped up in front of a provider and said, you need to do this for this patient because she's at high risk for this. One of the things could be an appointment request could automatically go out securely through their portal, through an electronic health record portal, to a patient's phone. This can happen by text, and it could be patient education, it could be patient monitoring. It really can truly automate itself, or it could send a referral out.
Right.
And structured data to request additional specialists or additional care.
So when we think about like when you're trying to track progress, you really have to have measures in order to understand like where you are now and where you want to go. And if we are not tracking something, right, then we have no way of identifying, well, where we are on that path. You may have a big idea, but like, okay, how do we map it out? And so you're literally in the process of trying to create that map,
Yes.
right?
Yes.
And like I just have so much admiration for what you're doing, because when I found out about what you were doing, I was just like, oh my God, it's about time. I'm so grateful, because we hear a lot about the problems, right? The problems, and we're just like, we can talk about the problems all day long, but ultimately, what are we doing about it?
Yeah.
And I was happy to hear that it was something that you're just like, oh my God, this is living in your head, the Dream Big initiative.
Well, it's,
yeah.
it's funny because here at HEMS, like just at a round table that we had yesterday afternoon, I believe. It's been a long week.
Yeah.
That was a solution for almost every table. So every table got assigned a different mission of how to accomplish something.
Okay.
And this could be included in literally every one of those, because it's really about maternal care, and it's really about outreach, and it's really about building patient trust and gaining access. And you have to be able to communicate with the patient to do that.
Yeah.
And of course, it's baby steps. You can start with
Baby steps.
you can start with different pilots, but start with community outreach programs. But even being able to communicate and build that trust with a patient and a provider is going to be huge. And that could be done. I mean, I don't like to get on the phone. I like to text. I like to see that. But just getting a text from that, I think, would be a big difference.
Well, I imagine that once you start to get this all kind of put together and more structured, that you're going to have a lot of partnerships, collaborations, and just a strategy around like who you end up working with, the areas that you get this implemented, and like hopefully get really far really fast.
So this is where it really blows up, because I did not realize how quickly this thing would grow and how big this thing could get. But I heard at one of the sessions this week that engagement is science. You have to have a strategic engagement, relies on, okay, I'm saying it wrong, but
It's okay.
there is a science to engagement. There we go. All right, so it's really important to have every perspective from every angle looking at things. And we have that. So we've got members from the National Institutes of Health. We've got members from the National Quality Forum. We have the National Committee Quality Assurance. We have the people that can make a difference, and we have it from every single patient, provider, hospital administrator perspective to make sure it's actually going to function. So we're still building advocacy internationally at this point, which is just blows my mind, because this just started. I mean, I feel like it's been a year, but I only started it, Sarah, in October, so I know it's not.
Yeah.
It just feels like it really blew up really quick. So a lot of great partnerships. Well, one of them too, sorry, because I want to mention this, because this was actually critical to getting these partnerships. Lauren Patrick introduced me to Dr. Sharon Hybe, and Dr. Sharon Hybe has worked on developing measures and specifically for National Quality Forum, CMS, in the past, and she was able to tell me specifically who we actually need to get put together this expert panel to be able to advise us on these, and she was a great connection for that.
That's great. I mean, because one of the conversations that we have a lot around with technology and healthcare in general is unconscious bias, right?
Yeah.
And so you want to make sure that whatever it is that you're building and creating, we can minimize that as much as possible. And especially when we think about the impact of the communities that we're trying to have better outcomes for, it's like Black and brown communities all over the world, and it's like we really want to make sure that we do better by them, essentially.
Yeah, so one of the things too, I think that's really important, because I'm learning new things every day. So for example, I learned that it kind of clicks every day. So think about the stress for a mother that contributes to pretty much any pregnancy complication. What if they were a top African American leader in health IT and this stress, and they're in the underserved population, and we know they're at high risk factor, and let's think if they have any other complication. So that's something I now have to factor in, and it's really cool, one, to see all these different concepts, but two, be able to put them into the measures so we can make this right. Like, we want to do it right.
Yeah, and I think it's important it's the active action of listening, right? And they're just like, okay, what voices need to be heard? How do we make sure that their, thoughts and insights are built into what it is that we're building out here, so that we can have best outcomes overall.
And continue to listen. So we've got members on the group for specific populations, but we make sure they're members that are listening and hearing other voices as well. So they're not representative of a population.
Sure.
They are just making sure that that population is heard.
Wonderful. Well, can we talk about a little bit more about you personally?
Sure.
Yeah. Did you know what you wanted to do when you grew up?
It's funny because I said this in the last one and I felt bad for it, but no, all I knew is I wanted out of Batesville, Arkansas.
Okay.
So I did whatever I could.
I know where I don't want to be, and
Yeah,
sometimes that's enough, right?
Yeah. I know I don't want to be here. I need to get into a big, diverse, open-minded space, and plus, explore what I can really do.
Okay. Were you born and raised in Arkansas?
Born and raised in Arkansas.
Okay.
So I tried to, this is kind of funny because I was the nerd that was not very popular. My brother was the popular one in high school. And so I tried to convince my parents to let me do homeschooling, and they just said absolutely not. So when I was 14, I started taking college classes at community college and just did it simultaneous to high school so I could graduate earlier. And it also added credit for bachelor's, so I could actually get out of there. So I graduated at 16, started Lyon College, so university type, not community college, and then was able to pretty much get out of town by the time that was done. And what was it? I'm just going to say a lot of years ago.
Okay. But how old were you? You were just like, okay, I got to get out. How old were you when you were able to do that?
22.
Okay. And where'd you go?
I went to Phoenix, and it was a culture shock,
I
to
bet.
say the least. Yeah.
How long did it take you to sort of like readjust, where you're just like, oh, I'm not in Kansas anymore, Arkansas.
It actually took a lot. So my fixin' to and buggies and that language didn't last very well. And then once you start speaking professionally, as you know, having a slang really puts that unconscious bias almost on it.
Yeah, sure.
So I got rid of that, started learning proper English.
Did you have to like be very intentional about that?
Yes.
Yeah? Mm-hmm. What did that entail?
Well, instead of like y'all, you guys, fixin' to, what am I fixin'
What is that?
to do?
What is
like,
fixin' to meaning? I mean to?
I'm
intending to. I'm about to.
Yeah.
Okay.
So yeah, there was a lot of adjustment, but now that the slang's gone, I kind of want it back, but it does come back sometimes when I'm in Arkansas.
Yeah, I bet.
Especially after a couple glasses of wine.
Yeah, I'm sure. But that's not where you live now. So you traveled through Phoenix, and where have you ended far?
No, I landed in Denver, Colorado. I love it there. So one, I grew up in the mountains and the woods in Arkansas. I need bigger, better mountains. So that's where I think I'm staying. And plus snowboarding, all of the fun sports, hiking, all of it's there. It's always blue sky and it's always sunny. So
no, isn't it like snowing there often?
It is, but it's actually the state with the most cloud-free blue sky days in the nation. Yeah, because it's a mile high up.
Oh, that makes sense. I didn't know that. Okay, so Denver. Okay, that's great. You love it there. And then, this is what I was going to go. So, would you be blowing your mind? Do you think 10-year-old Holly has any idea of what you would be doing for, like, what would 10-year-old Holly think about what you do?
I know that I tend to get started on something and try big things and then just keep going with it. So 10-year-old me wouldn't have had a clue. Maybe 14-year-old me might have had an initiative, at least knowing that I was going to do something big, be something. And at the time, no, it was like, oh, I'm going to be a CEO of something. Mm-hmm. And then you get out and you start to live the real world, and then it kind of extrapolates. But no, 10-year-old me was playing in the dirt in Arkansas. Yeah, so they're like, no, not at all. Which is awesome, too.
Well, I think you definitely have displayed courage, bravery, taking on big challenges. What advice would you give to other women who are, perhaps in a similar position or starting out their careers?
So, competency, feeling competent.
Yeah.
Feeling confident in what you can do.
Yeah.
And I heard the fake it till you make it, but honestly, you have to know that you're going to do something before other people will know you're going to do something. So you need to have that out there. You need to have that type of thought process that I'm going to do this, and I'm going to do it very well.
Yeah,
So.
a belief in yourself. And there's something that's come up for me lately, and I don't mean to like take over, but it's sort of the idea of like investing in yourself. Like, I think if I would ask myself this question, I would say, you know what, like education, self-awareness, things that like really knowing yourself and really like coming to a place of like investing in things that have to do with you as an individual that nobody can take away from you.
Yeah.
That even if you change jobs or change cities or, you know, change a whole lot of things, that they're like within you.
The uniqueness, that's like the slang that got taken away. It's the uniqueness, it's the personality and finding those things that you have core strengths in. I agree completely.
Yeah, and I think it's something that it's like regardless of your path and where you end up applying your skills, that you get to take it with you, right?
Absolutely.
Yeah.
And it's always yours, and you can always come back and remember that you have those things.
Exactly. Well, I am wishing you so much luck on your journey. You are about to climb a big mountain. And so I want to find ways that we can like support you and make sure that you have like the community and expertise to help you on your way, because I really believe in what you're doing. So I wanted to say thank you for coming on the show. And if people want to find you or get in touch, what would you recommend? How would you direct them?
You know, it's really crazy. I put my name in Spotify, like my full name in Spotify, and Alexa popped it up the other day for one of the podcasts, and I just mind-blowing for me, coming from Batesville, Arkansas. You know, like Alexis is... Anywho.
Wait, should I find you in Spotify? Do you have good playlists?
No, it was the podcast that I did. That was, no, not that good. But no, LinkedIn.
LinkedIn is
that's usually the best. And just Holly Varnell.
Okay, wonderful. We will include that in the show notes. Thank you so much, Holly.
Well, thank you for having me on, and thank you for the active engagement and believing in this. It's awesome.
I am dreaming big right there with you.
Perfect.
All right. And thank you for watching. This has been Hit Like a Girl Pod. You can follow us online at hitlikeagirlpod.com or follow us on socials at the handle Hit Like a Girl Pod. Thank you.